To explore vasculitis. And in this we are going to discuss about large vessel vasculitis, medium vessel and small vessel vasculitis. So in large vessel vasculitis we have the temporal arteritis, very important, and Takayasu arteritis. Okay. Medium vessel vasculitis we are going to discuss polyarteritis nodosa, Kawasaki disease, Burkitt's disease. And in small vasculitis, we're going to only talk about Beckner granulomatosis, microscopic polyangiitis, Church-Strauss syndrome, and Henoch-Schönlein purpura. Okay, so the best way, I think that, of course, everybody has their own way of teaching this, but the way I have organized it in a tabular form. Okay, so this makes it easier to remember stuff, because everything gets so confused. So I made like, this is how I learned this vasculitis. So first we do large vessel vasculitis. So let's start with temporal arteritis. So first, what kind of arteritis it is? It is granulomatosis. Okay, granulomatous type. What are the vessels that are involved? Carotid arteries are involved. And in carotid arteries, temporal artery and ophthalmic artery, they were involved. And ESR is always elevated. If you do the labs, ESR is elevated. In demography, you're gonna have it in females who are older than 50 years old. See? So if in a clinical vignette, if it's someone who is female and is more than 50 years old, it is temporal arteritis. Okay. Clinical manifestations: headache, visual disturbances, visual disturbances with risk of blindness. This is very important, very important. I'll tell you, with the drugs you use corticosteroids. It is important, very important, that you give corticosteroids before doing biopsy. You give corticosteroids before doing biopsy, okay, to minimize the chances of blindness. What are other manifestations? Jaw claudication, flu-like symptoms, joint and muscle pain, that is called as polymyalgia rheumatica. And what is biopsy? In biopsy you see inflamed vessel wall with giant cells. Okay, so that is the name entails, the giant cell arteritis. Giant cell with intima, the tunica intima is fibrosed, and all these, the fibrosis is segmental in nature. They are segmental lesions. Okay, so that is it. That is everything you need to know about the temporal cell arteritis. What about Takayasu? So Takayasu arteritis is granulomatous. Okay, what are the arteries involved? The aortic arch. Okay, aortic arch. It's a large vessel, right? So aortic arch, and it involves damage to subclavian artery. That is why it is also called as a pulseless disease, because there is no BP or uneven BP. There is uneven BP in upper extremities or upper limbs. Okay, in upper extremities. So that is why it is called, and you can feel no pulse. So that's why it is called as a pulseless disease. What other things that you can have? Because it's an aortic arch, right? So brachiocephalic is also being affected, and all the things are affected. So that is visual symptoms and neurological symptoms. Big carotid is also affected. And very important, the demography: Japanese female less than 50 years old. Okay, so Takayasu is a Japanese name and the female is also Japanese. Okay, biopsy will show transmural fibrosis and treatment is corticosteroids. Okay, both have corticosteroids. Right, now let's move on towards medium vessel vasculitis. We have 3 in this. So let's do polyarteritis nodosa first. So in polyarteritis nodosa, what type of it is? Necrotizing. It is necrotizing. It is not granulomatous. It is necrotizing. Demography is young adults. Vessels, multiple organs, but eventually the most important thing is that lungs are spared. Okay, this is very important. What are the 2 most common arteries that are involved? Renal artery and mesenteric artery. So you see now the clinical manifestation. Renal artery is involved, so you have hypertension. Mesenteric artery is involved, so you have melena. What other things you can say? Neurologic symptoms and skin lesions, because it's multiple organs are involved. Biopsy. Early biopsy will show transmural inflammation. Okay, and you know that in vessel, what kind of necrosis usually happens? Fibrinoid necrosis. It is a concept of general pathology, right? So it's fibrinoid necrosis. And late, after fibrinoid necrosis, when necrosis resolve, what happens? Fibrosis happens, right? So what kind of appearance? It will be string of pearl appearance. Okay, very, very important. String of pearl appearance. You don't see it in any other vasculitis. Important association, hepatitis B, and it will be a surface antigen. Okay, so it will be the active infection, and that is the big association in polyarteritis nodosa. The drug therapies will be cyclophosphamide and corticosteroids. Okay, now we have cyclophosphamide here as well. Let's move on to Kawasaki disease. In Kawasaki disease, what is demography? It is in Asian children less than 4-year-old. Okay, less than 4, and what? Asian. Very dangerous disease. It is coronary artery involvement. So risk of MI because it can thrombose. Okay, and aneurysm that may rupture. Okay, it can rupture, and MI is because of thrombosis. So what is the clinical manifestations? There is a mnemonic, crash and burn fever. Okay, crash and burn. C is for conjunctivitis. So unrelated symptoms will be there. Rash, adenoma, strawberry tongue, hand and feet will have rashes, and burning fever. Okay, there is no biopsy or association, but there is drugs are important here. Aspirin and IVIG are given to prevent what? To prevent myocardial infarction. Here I want you to know that usually in children we never ever give aspirin, right? Because aspirin can cause what? Rye syndrome in children. What it can cause? Rye syndrome in children. But in this case, we are giving aspirin in order to prevent MI, right? I mean, with Rye syndrome, of course, there is like a very toxic, it's very dangerous for children. But MI is more dangerous than Rye syndrome. So what do? We do give aspirin. Okay, so yep, we do give that. So you need to know that we will never give aspirin in any other case. We are only giving aspirin in Rye syndrome and also IVIG, and it is also self-limited, so you need to know that. Then we have Berger's disease. It is also necrotizing. What it involves? It involves digits, and the clinical manifestations are Raynaud's phenomena. What is Raynaud's phenomena? Raynaud's phenomena is that the digits, they will first turn white. Why would they turn white? That's a question. Now, what is white to blue to red? White is when the blood supply is cut off. White will, when complete cut off, the blood supply cuts off. And blue, when it turns blue, it means there is ischemia, right? And red means reperfusion has occurred. That is why the series of color is important. First white when complete ischemia, okay, complete blood cut off. Of course it will be white, but it will then progress to ischemia. It will start to die, necrosis. That will be blue, and then the arteries will open up again, and blood will reperfuse. So the color will be red. Okay. So what is the biggest association? That is the heavy smoking. And what is treatment? Cessation of smoking. See, so easy. Now let's do small vessel vasculitis. The first is Wegener's granulomatosis. That is necrotizing. It is necrotizing type. Vessel involvement is nasopharynx, lungs and kidney. So according to Pithoma, and Hussein Sattar, he gave a very nice mnemonic, and I will also go by that mnemonic because why not? And in this he draws a stick man and writes a C. Sorry, let me change color. And he writes a C. And in this C you see that the nose is involved, the lungs are involved, and the kidneys are involved. So nasopharynx, lungs and kidneys. So you also have to pronounce Wegener's as Wegener's. Okay. And demography, what is demography? Middle-aged male. This is the only male disease you have seen. in all vasculitis. Okay, what are the clinical manifestations? Sinusitis with nasopharynx and ulcers, hemoptysis and bilateral nodular lung infiltrates because the lungs are involved, and hematuria and rapidly progressive glomerulonephritis with kidneys. What are the serum levels? C and K. C for Wegener, and C, we drew a C here. So C and K against proteinase 3. So C and K is actually cytoplasmic NK, okay, and it is against proteinase 3. What are the drugs? Cyclophosphamide and steroids. Okay. Now let's move on towards microscopic polyangiitis, that is also necrotizing and also occurs in multiple, but it involves lungs and kidneys. No nasopharyngeal involvement. That is why these both are similar. Okay, these both are similar, but in this nasopharyngeal you will find sinusitis and ulcers, and in the below one you won't. Everything else is similar. Okay, so this is also similar. Okay, similar. And but there is P and K against MPO, myeloperoxidase. P and K is peripheral ANCA or perinuclear ANCA around the nucleus. Okay, I'll tell you this. What I'm talking about is that, for example, this is your little cell and this is your nucleus. Okay, this is your nucleus. So where are you going to find the P and K? The P and K will be around the nucleus. And where are you going to find the C and K? C and K is in the cytoplasm. Okay, so C and K and P and K. Okay, what are the drugs you give? Cyclophosphamide and corticosteroids. Then we have Churg-Strauss disease. Churg-Strauss disease is also called as eosinophilic granulomatosis with polyangiitis. So you need to remember this because Churg-Strauss was a Nazi German, and most of the books and even examiners don't use this word. So let me write it out for you. But in many other books it is still used, but I'm still going to write it out for you guys. So eosinophilic granulomatosis with polyangiitis. Alright, and what happens here is we have multiple organs but lungs and heart. Okay, lungs and heart. And what are the clinical manifestations? Asthma with peripheral, sorry, this is peripheral eosinophilia. This is peripheral eosinophilia. Sorry. Eosinophilia, peripheral eosinophilia. Okay. And what are the serum levels? P and K. There are no drugs. Henoch-Schönlein purpura. Henoch-Schönlein purpura is most common in children. This is the most common children. What is the presentation? Palpable purpura. After what? Upper respiratory tract infection, post-strep and hematuria. PSGN. You can, PSGN, because why? Because it's an IgA nephropathy. IgA immune complexes are being deposited. And what is PSGN? Sorry, not PSGN. Sorry. This is IgA nephropathy. IgA nephropathy, hematuria. What is the treatment? Steroids is the treatment because it is also self-limited, but steroids is the treatment. So, of course, there are a lot of German names and Japanese names, but these tables have made it very easy. So you can take screenshots. Let me make it like so that you can take a screenshot for large vessel vasculitis, and for the medium vessel you have to do it bit by bit. This is one, polyarteritis nodosa, and then for Berger's disease and Kawasaki disease, and then for small vessel vasculitis bit by bit again. Here you go. And then for the last one. Okay, so here we've done temporal arteritis. It's very important. Temporal arteritis is very important. Okay, very important. And then you compare it with Takayasu. And then polyarthritis nodosa, Kawasaki and Buerger's. Buerger's is super easy with smoking. Buerger is with smoking. Kawasaki with young children and aspirin and all that story. Polyarthritis nodosa is with fibrinoid necrosis and string of pearl appearance. Temporal arthritis is with what? Visual disturbances, right? Takayasu is with what? Pulseless disease. Wegener's granulomatosis, you draw a C and it's a C ANCA, okay? Nasopharynx, lungs and kidney. Microscopic polyangiitis, what was it? This is P ANCA, okay? P ANCA. Churg-Strauss syndrome. Churg-Strauss syndrome was what? Lungs and heart. And eosinophilia, okay? The most important is eosinophilia in Churg-Strauss syndrome. And Henoch-Schönlein, IgA immune complexes, okay? So that's also a revision. These are the important points and this is very easy. Thank you so much.